Okay, let's finish up by talking about stomach disorders. All right. The first one that we want to talk about is gastritis. Gastritis is an inflammation of the gastric mucosa. So stomatitis was in the mouth, esophagitis is in the esophagus, and gastritis is in the stomach. It may be acute or it may be chronic. I'm not concerned that you tell me type A versus type B. It's just there for your information. Okay? But acute usually happens from an onset of an infection. Okay? Either H. pylori, which we'll talk about, which is a gastric infection, or E. coli. It may happen after exposure to some type of irritant to the mucosa. Again, there's that alcohol business again. Alcohol, aspirin, ingestion of corrosive agents. Or acute may happen because there's a lack of stimulation of the normal gastric secretions. Okay. What you have are varying degrees of necrosis and inflammation, and regeneration and healing usually starts, bless you, times 2. Regeneration and healing usually occurs within a couple of days. Your patient has a complete recovery with no residual problems. These are your folks with the stomach bug. Okay? However, with an acute gastritis, your patient is more prone to hemorrhage. It's an acute onset, an acute presentation, and then it goes away. Chronic lasts is a little more chronic. It has a lengthier stay with the patient. Okay, it's a very diffuse inflammatory process. And it usually heals without scarring, but you can also hemorrhage from this too. The acute one is a little more easier to hemorrhage than the chronic. Okay? When we're talking about H. pylori, as I said, that's a gastric infection. And the Helicobacter pylori, that's what that stands for, is a bacteria, and it penetrates the mucosal gel layer of the stomach, okay, of the gastric epithelium, and it's very irritating, and it's a chronic issue. So patients who present with acute gastritis are miserable people. They have abdominal tenderness and bloating. They're cramping. They're nauseated. They're vomiting. They may have vomiting of blood. They may have blood in the stool. And your patient can actually have a gastritis that's actually comes from stress. Okay? Stress-induced gastritis. These folks are really even more sick. Okay? They have signs of intravascular volume depletion. They have signs of shock. Patients with gastritis from aspirin and NSAIDs usually just have heartburn and dyspepsia. Your chronic gastritis folks have kind of vague complaints. The stomach just hurts all the time. Just sore all the time. I just don't feel right. Everything makes me sick. Okay, just vague kind of thing. They have periodic episodes, and usually it's relieved when they eat. Okay. You put food in there for the gastric secretions to work on, instead of working on the mucosal layer of the stomach. Pain is worse after they eat spicy and fatty foods. And then these folks have weight loss, chronic weight loss, because they just don't eat. So what we do is we do an EGD. We look down into the stomach. We may take a biopsy of the stomach wall, and in that case we're looking for H. pylori, looking for a chronic condition. If it's an acute condition, they can tell because the stomach is obviously inflamed and infected and got a lot of damage going on in there. Okay. So when we're talking about how to treat it, we're going to start out with gastritis, treating it with the drug therapy. Okay? We're going to start our H2 agonists, and these are the same type of medications that we talked about with GERD. Pepsid, okay, that blocks the gastric acid secretion. We're going to give them antacids to buffer some of the acid. We may put our patient on Carafate. Now, Carafate is a medication, it's an oldie but a goodie. We give a lot of that. What it actually does is it coats the mucosal layer. Okay. Carafate, Carafate. And what it is, it's a mucosal barrier fortifier. Okay, it helps to cover the mucosal layer. Okay. Your patients may need vitamin B12 if their gastritis is causing them to not be able to absorb vitamin B12. They get into pernicious anemia, and we'll have that discussion probably in about 4 weeks. We'll talk about pernicious anemia. Okay. Your patients are going to be put on proton pump inhibitors and antibiotics if the reason is H. pylori. Teaching them to avoid those irritating things, spicy, fried, acidic type things. And then we're going to put our patients on a soft, bland diet. Small meals, give the stomach time to recover. You may be on for several months. Yeah, you may be on it several months. It's a long-term therapy for H. pylori. And then your patient usually needs to have some type of stress management education. Okay. Our goal with gastritis is we want to treat the symptoms, treat the causes, and eliminate the causes. Okay. Your H2 agonist blocks the secretions, okay? Your PPIs block the production of gastric acid. One of them stops the production, one stops the secretion. All right? If your patient has a GI bleed from gastritis, keep in mind they may have to have blood transfusion. So anything stomach-wise, your patient has a risk for a bleed. The stomach is very vascular as well. Okay? So peptic ulcer disease is the other one that we talk about when we're talking about stomach problems. This is when we actually have lesions in the stomach or the duodenum. Types, they may be gastric, it may be duodenal, or it may be a stress ulcer. So you can have stress gastritis, you can have stress ulcers, but the lesion develops when the mucosal defenses become impaired and can no longer protect the epithelium from the gastric acid. Okay. Your patients can develop peptic ulcers from a variety of issues, okay, and things. But when they develop ulcers because of stress, these are usually very acute, and they're usually a crisis, okay? These are the ones that bleed very easily. And your patient, they don't just bleed, they hemorrhage. These are not oozing ulcers, these are hemorrhaging ulcers. So medications, infection, anything that can damage the lining to the stomach can cause the patient to have a peptic ulcer. Some conditions, chronic conditions like cirrhosis of the liver, COPD, and pancreatitis damage the inner lining of the stomach and can lead to ulcers. Okay. So ulcers that come from surgery or from a prolonged hospitalization. What kind of surgery, what kind of ulcers do you think those are? They're stress ulcers. Okay? They're stress ulcers. So that's why we're giving the protonic. And we're doing things to prevent that ulcer formation. Because remember, those are the bad boys. Those are the bad boys. Okay? Did you have a question? Pancreatitis, yes. Uh-huh. Mm-hmm. Because it affects the gastric acid secretion. You have more of it. Okay. So, complications from peptic ulcer disease. Hemorrhage is your number one. Your hemorrhage varies in severity. Okay, it can vary. But with duodenal ulcers, you're more prone to see blood in the stool, whereas with gastric ulcers, you're more likely to see hemorrhage in the vomitus. Okay. Remember, it's up higher. Perforation is a complication. The ulcer can just eat through the gastric wall. That's when you have stomach contents that are actually entering the abdominal cavity. That's not good. That's not good at all. Your patient gets peritonitis. They usually complain of very, very sudden, sharp pain in the abdomen. It usually starts here, and then it just spreads all over the abdomen. It's very, very painful. Your patient may be very critically ill in a very short amount of time. This is an emergency. This patient's got to go to surgery immediately. Okay. Pyloric obstruction is where you actually have an obstruction at the pyloric valve in the stomach. This can come from recurrent scarring or edema or inflammation there at that sphincter. So if my stomach is blocked off, what do you think you see? It's coming this way. It's not going through. It's coming this way. So you have nausea, vomiting, some bloating, okay? No, that's fine. Inflammation. Sure. Your patients may have intractable disease. That just means despite treatment, your patient continues to form ulcers. The pain and discomfort recurs, and it really at this point starts to interfere in their daily life. Okay. So what we see with these folks is, usually epigastric discomfort, abdominal pain and tenderness, cramps, indigestion, nausea, and dyspepsia. You want to assess for any stressors that they have, either real, actual stressors or what they perceive as a stressor. You want to assess their hemoglobin and hematocrit. They may be low if the patient is bleeding. Their pain that they have, if it's a gastric ulcer, usually food will relieve the pain, but duodenal, the pain may happen after eating. Excuse me, sorry. Now, when we're talking about GI bleeding, upper GI bleeding, this is more often seen in your elderly people. Because they use a lot of over-the-counter stuff to take care of their indigestion and all that business, and actually it may delay treatment for their ulcer. However, anybody that's got an ulcer has a risk for GI bleeding. Upper GI bleeding is an emergency. I've never seen anybody just bleed that it wasn't an emergency. Your patient will have bright red or coffee ground emesis. The longer that blood is in the GI system, the darker it gets. Okay. So your patient may have what we call tarry stools, black stools, melena, which is occult blood. This is one of those things that your patient may be bleeding internally and you don't know it. Okay, you have to, your assessment needs to find those kind of things. Blood pressure will drop, and they have syncopal episodes. And you just have to use your, like I said, you have to use your assessment. Patients may be bleeding into the stomach, and you're watching their abdomen. Their abdomen may be getting rigid, board-like, distended. So peptic ulcers perforate, they bleed very easily, and it does take a little while for their blood pressure to drop, and I learned that night as well. We're going to diagnose peptic ulcers with a barium swallow and an EGD. More likely an EGD in this day and age. Okay, too easy to look. So what do we do for them? We manage the bleeding and the hemorrhage if we have that issue, okay? But we're also going to take care of their pain. Peptic ulcers are usually painful. So we control their pain. We give medications. If their ulcer is because of H. pylori, we usually put them on what we call triple therapy. They get put on a proton pump inhibitor like Protonix, and we usually give them 2 antibiotics. And the 2 biggies are Flagyl and amoxicillin. We may give our patients antacids and then the H2 agonists. We've got to maintain their fluid volume. Patients with ulcers lose fluid because of hemorrhage. Yes. Then they'll give them something else. Maybe a tetracycline or something like that. I'm not going to hold you to that, okay? Because that's physician's preference, okay? It may be one of the mycins, like gentamicin or something that they give. Okay? So managing their fluid, hypovolemic, hemorrhage, and we've got to treat perforation. Perforation is always a surgical issue. You've got to take them to surgery. Okay? But to monitor hypovolemia, we're looking at vital signs, strict intake and output. We're monitoring their labs. These folks usually need 2 large bore IVs going, and they're probably going to need that, and they're going to need blood administration. We're monitoring their hemoglobin and hematocrit, those labs. Those will fall a little late as well. Okay? This guy's blood work that came back was normal. So blood pressure had not started to fall, and his H&H was still okay. Patients that are hemorrhaging will have an NG tube put down. You're probably putting that down to empty the stomach. And then we may actually need to irrigate the NG tube to keep it patent. They may have clots in there that we need to get out of it. And so you may be doing some hand irrigation with saline or water to get that out of there. I think your book says that your perforations may close spontaneously, but most of the time I think they're going to take them to surgery, especially if they've got a lot of profuse hemorrhaging. Okay, those folks are going. They got to get that bleeding under control. Okay. These folks need stress management, and these people also need diet control. We've talked about that for everything. Frequent small meals. And they need to avoid the things that cause them pain. Okay? It's spicy. Every time I eat spicy, it causes my ulcers to act up. I need to stay out of Casablanca. Wow, that's hard. Okay. Surgical management for peptic ulcers. Again, we may be removing part of the stomach. Or part of it, or total, which is a gastrectomy. A vagotomy cuts the vagus nerve to parts of the stomach, and that actually affects the gastric secretion, gastric acid secretion. So that's how that works. Sure, a vagotomy cuts the vagus nerve to part of the stomach, and it affects gastric acid secretion. And, of course, surgery to close the perforation. So what do you think routine post-op is on these people? Ooh, good. Okay. Airway, absolutely. What else? Are they going to have an NG tube? Yes, they will. And are you playing with it? No, you're not playing with it. Okay. Monitoring INO, monitoring electrolytes, monitoring vitals, turn coughing and deep breathing, all those things we've talked about, right? Good. Good, good, good. Now, one other thing I want to talk about are post-op complications. When we go in there and we start removing part of the esophagus, the stomach, or part of the intestine, we get into some of these complications right here. Okay, so I'm going to tell you what each one of these are. Acute gastric dilation. This usually happens immediately post-op, and your patient complains of epigastric pain, tachycardia, their blood pressure drops, and they usually have a feeling of fullness. Okay? This patient may need an NG tube. Epigastric pain, tachycardia, blood pressure drop, and they have a feeling of fullness and hiccups. So it's an immediate reaction, and we usually put an NG tube in to decompress the stomach. Okay. Now, dumping syndrome usually happens from a quick influx of carbohydrates. Okay, you're going to see dumping syndrome again when we talk about diabetes. Okay, but what happens here, it happens after eating, and it's a rapid entry of food into the bowel. It's a sudden dumping into the bowel. What happens is your patient has vertigo, they're sweaty, they're pale, they're tachycardic, and they feel very full in the epigastric area. So what happens is, this is usually when you have stomach surgery, gastric surgery, pyloroplasty, surgery on the pyloric sphincter. Okay, so early is usually when it happens within 30 minutes of eating. Okay, but you can have a later dumping syndrome, which happens hour and a half to 3 hours or so after they eat. That's the one that happens more often because of the diabetes. Okay, you eat the meal and there's a rapid influx of insulin. Okay, but the early is usually because of a gastric surgical procedure. So what we do is we decrease the amount of food that they eat, small meals, high protein, high fat, low carb. Now these folks, we want them to be semi-Fowler's position to slow down the gastric emptying. So semi-recumbent or semi-Fowler's position. And then once they eat, we want them flat. That goes against everything you've ever heard since day one in here, doesn't it? These are the folks that we don't want things emptying quickly. So we want them laying low while they're eating, and then once we're through eating, then they lay flat. We may even have to give them sedatives or antispasmodics to slow down the gastric emptying. So dumping syndrome, fast exit into the intestine, or from a sudden release of insulin. This we'll talk about with diabetes. Okay, alkaline reflux gastritis is where we have reflux of the duodenal contents backwards into the stomach. Okay, this is not reflux into the esophagus, but reflux from the intestine into the stomach, so it's alkaline. Okay, it damages the mucosa. So again, you have abdominal pain, vomiting, those kind of things. Your patient may have delayed gastric emptying, which is just exactly what it says. Okay, there's something, inflammation, that or a stricture, something that's preventing the stomach from emptying. It empties slow. Usually this resolves about a week after surgery. You have to give things time to settle down in there. No. You're starting them off slow, so you're trying not to overfill them. You're starting their feedings off slow and seeing how they're tolerating it. But when this starts to happen, then you cut down on their intake. Okay. Again, you may need some antispasmodics for this, those kind of things. Let's see. Afferent loop syndrome. This is due to a blockage of the duodenal loop, and it's usually due to a resection. Okay, scarring, maybe. Sure. Blockage of the duodenal loop due to resection. The patient usually has painful contractions, as it's trying to work things through that blockage, vomiting and bloating. Vomiting and bloating. Bloating, yes. Sorry. Your patient may get a recurrent ulcer, especially if they have H. pylori or that intractable type disease that we talked about, or if the vagotomy just was not complete enough. Vagotomy will affect certain parts of the stomach. So maybe if it was incomplete, you're still getting that gastric acid secretion. And then anybody who has gastric surgery will have the risk of electrolyte and nutritional deficiencies. And if they've had part of the stomach removed, remember B12, where is it absorbed? In the stomach. So if my patient has had their stomach removed, your patient is going to have B12 supplements for the rest of their life. They have no other way of getting it, right? Okay, so we may have issues with B12, issues with iron, issues with folic acid, and they may also have problems with calcium and vitamin D. So we're looking at bone issues in that case.